Hello, my name is Dr. Carl Michel. I am a practicing foot and ankle surgeon at Genesis Foot and Ankle Institute, as well as board member of Leroy Jefferson Medical Society, where I currently serve as parliamentarian, health fair, and health education chair. Leroy Jefferson is made of healthcare professionals dedicated to improving the health and wellness, access to care, academic and career opportunities and the quality of life of our underserved populations through the provision of healthcare, education, career exposures, and youth development services. Thank you for electing to take this opportunity to learn. We hope you find this offering valuable in your everyday life. If you would like more information on Leroy Jefferson Medical Society, please visit our website at tljmedicalsociety.org.
Tonight, the first of a 5-part series on the opioid epidemic. A panel of experts shares insights from all angles.
But I found it extremely difficult because it broke my heart to see these infants going through this.
The impact on children, adults, and families.
Those children grow up seeing that this is normal.
The barriers to effective treatment.
I think the greatest barrier is the patient's willingness to confide in her provider.
And we take a look at real solutions.
All of these recommendations, we can get you from a state of dependency to a state of independence.
And how all of us can help law enforcement.
We depend on healthcare experts, doctors who are at the front lines of this to help us identify the problems, to help stop the problem before they begin.
Hi, I'm Sandy Collier, and I'm your host this evening. Thank you for joining us for our series on opioids, presented by the Leroy Jefferson Medical Society. I have the pleasure of having Dr. Deborah Jones with me this evening. Dr. Jones, thank you so much for joining us. Let's start with you telling us a little bit about yourself and your practice.
Hi, how are you? Thank you for welcoming me this evening. I am an obstetrician gynecologist who specialized in maternal fetal medicine. Maternal fetal medicine is the study of the fetus and the high-risk mom. I've been in West Palm Beach for the past 25 years. I am in practice with several women, and we let one man work with us, and we take care of most of the community's high-risk moms and their unborn babies. We work out of St. Mary's, Wellington, Bethesda, and one of our partners works out of Boca Regional Hospital.
So, Dr. Jones, describe the types of patients you see in your clinical setting.
Well, we see a variety of patients. Most of them are, as I said, high risk, and that could be for a variety of reasons. One, maternal reasons such as high blood pressure, diabetes, recurrent pregnancy losses, obesity, multiple pregnancies, and patients suffering from substance use disorder.
Doctor, can you explain what SUD is?
SUD is substance use disorder. Many patients have poly, meaning many drug use. They many times do not solely use opioids. And so I like the terminology substance use disorder as opposed to opioid use disorder.
And you just started touching on that. Let's talk a little bit more about the factors of a high-risk pregnancy.
The factors. So, as I was saying, could be maternal reasons if a patient has high blood pressure or diabetes, if they have twins, if they've had previous preterm delivery of their baby, if their baby has congenital anomalies, of the heart, of the brain, spinal cord. These are some of the patients that we would see in our practice.
Doctor, I'm sure addiction starts from somewhere. So, what are some of the pre existing conditions that put pregnant women at risk for an opioid addiction?
Oh, I don't know if I could pinpoint a pre-existing condition for opioid use pregnancy. That's a $1 million question, and I don't think that anybody knows whether you're pregnant or not pregnant. Why some people have a substance use disorder. Uh, why some people continue when they're pregnant, why some people are able to stop when they become pregnant. Uh, that is not an easy answer. That's not an easy question, excuse me, to answer.
How do you identify a pregnant woman who has an opioid addiction?
Well, they can come to us from several different avenues. They could already be in a treatment program and be referred to us. They could be referred to us by their primary care doctor. They could be referred to us by the OB doctor. And usually this is via their history. Sometimes the patient comes seeking help. Sometimes it's identified at the time of taking their history and finding out that either current or in the past they had substance abuse uh, disorder. Or some practices, it's found out at the time of a urine drug screen. There are some practices that require all their pregnant women to have a pregnancy drug screen, and that's the time that they find out. There are also times when the courts also refer the patient to us for prenatal care.
What are the limitations to drug screening, doctor?
Yeah. So there are multiple limitations. One, the most important one, I think, is buy-in from the patient, because the patient has to give you permission to do the drug screen. You need informed consent in order to do the drug screen on a patient. Secondly, uh, drug screens are many different kinds of drug screens. So there's some drug screens that hit the most common drugs that are used. And then there are more comprehensive drug screens that try to incorporate as many drugs that we know that are abused. And so therefore, you have to know what you're looking for, or you just do the shotgun approach and order the most comprehensive drug screen, which sometimes is not what most practices do. They do the most common drugs.
So, having said that, what are the other barriers to determine if a woman has an opioid addiction?
I think the greatest barrier is the patient's willingness to confide in her provider. Because most of the time you're going to get this through history taking. And if you do not break down the barriers so that that patient can confide in you in an environment that's non-judgmental, then it's difficult to find out who is using and who's not using, unless of course they've come to you openly and admitted that they're using, or they've been sent to you from a treatment center, or as I said, from the legal system.
Why is getting a woman's history so critical for her treatment? And at the same time, why is that so difficult? Can you talk a little bit about that?
Yeah. Well, unlike other chronic medical diseases like high blood pressure or diabetes, or if you had your baby early, or if you have a family history of, uh, you know, uh, let's say, for instance, psychiatric disorder, people are ashamed, I think, one, of their history of substance abuse, especially while pregnant. And secondly, it's a fear. It's a fear that there will be consequences if they confide in their healthcare provider that they have substance use disorder. And the fear is because in many states, it's reportable, especially in Florida, if your child is born with a positive urine drug screen, which would be a natural consequence of you admitting that you use drugs during pregnancy. And then a fear of incarceration, which is in some states, something that happens to women who are using during pregnancy.
How important is it for a pregnant woman to have a strong support system when undergoing treatment for opioid abuse?
Oh, that's the most essential part of it. For a woman to go through treatment successfully, it's the foundation of her success is a strong support either from family, friends, her provider, the system in general. Needs to support women who have opioid use disorder.
That brings me to another question, doctor, because what I'm hearing from you is in order for that to happen, there has to be a degree of trust. How do you build that trust with your patient?
Well, that's the difficult part. As I said, for the most important thing is for them to sense that you're non-judgmental, that you're not judging them for using during the pregnancy, that you recognize that it is a medical problem. That's based on, the language that you might use, so that they understand that you're supporting them and not criticizing them for something that is usually not easily controlled.
What are the main drugs used now to treat opioid addiction?
Well, there are many drugs to treat opioid addiction. The drugs that are used in pregnancy are limited because they haven't done a lot of research and studies with all of the drugs in pregnancy. Methadone is a drug that's been used for 20, 30 years, maybe more, in the treatment of opioid addiction and pregnancy. And more recently, Subutex and Suboxone, which are also named buprenorphine and buprenorphine plus naloxone, have been gaining favor in the treatment of substance abuse or opioid addiction in pregnancy. And the main difference between the two drugs, other than methadone has been around for a long time and Subutex and Suboxone are newer drugs, is that number one, for methadone, you have to show up at a methadone clinic every day and you get your medication allotted to you. Buprenorphine and naloxone, you can go to a private practice doctor. And if that private practice doctor has a license, he'll be able to write that for you. If not, then you're at a treatment center and you can get this medication. How does this medication have to do with the outcomes of pregnancy? Methadone babies have a higher risk of withdrawal from methadone than they do from buprenorphine or Suboxone. So that's one reason why people nowadays are really favoring buprenorphine and or Suboxone over methadone.
Doctor, in terms of people of color and non-minority communities, talk about how the different medications are used or prescribed, such as methadone and other drugs?
Okay, well, both drugs can be used in, any community, but what's was the gold standard for opioid addiction was methadone. Methadone is usually dispensed in a clinic. A lot of times, people of low income and traditionally minority would get their medication from a methadone clinic. Recently, buprenorphine, which is Subutex, and another drug by the name of Suboxone, which is buprenorphine and naloxone, could have taken over treatment for opioid addiction. The problem is that's a very expensive medication. The medication is usually given in a physician's private office or sometimes at treatment centers. And unless you have the funds to have a private insurance to purchase your medication, or if you're in treatment, then you see there's immediately, just from a socioeconomic point of view, big disparity. And that sort of bleeds into the racial disparity. Now, recently, some Medicaid, again, you have to be insured, some Medicaid AMOs will cover Suboxone and Subutex if the patient finds herself in a treatment environment. And it has to be a very regulated treatment environment for Medicaid HMOs to cover the medication.
So, in terms of the treatment, what I'm hearing from you is that there is a cost issue that needs to be addressed to be able to combat this problem.
Yes, in a sense, yes. You know, for you to have equity, everybody should have access to the best medication, regardless of cost. And today, that's buprenorphine or buprenorphine and naloxone in pregnancy.
So, Dr. Jones, talk about finding the balance of using medications or psychological services in detoxifying an addicted pregnant woman.
So there is there's a balance to be had. The difficulty is that 20 to 90% of women that try to detoxify with any medical assistance during pregnancy, despite good therapy, can relapse and overdose. So, detoxifying pregnant women is not the standard of care. The standard of care today is moving them from a opioid such as heroin or Vicodin to a medication such as buprenorphine or methadone, along with treatment to support them throughout their pregnancy and post delivery.
Dr. Jones, let's talk about race and addiction. There is an issue with minorities and their trust of doctors. How does that play a role in their addiction treatment?
Very, very interesting question again. There's disparities in opioid use, treatment, and even management of pain in minority patients. So let's talk about first the disparity in use. We think that sometime about 10 years ago, the amount of opioids used in minorities and non-minorities, or white, non-Hispanic, blacks, were about equal, but has increased significantly in the white population. At least that's what's recorded. Is that what's true? If that's what's on the ground is different, but what's reported is that it's a higher use in whites as opposed to non-whites. The treatment disparity is that most, and again, this is earlier on in the crises, more non-white women were incarcerated, detoxified, as opposed to whites. There's current literature that indicates that more whites are either being offered or are using medical treatment, such as buprenorphine, for their opioid use, and are seeking treatment versus non-whites. Less non-whites seeking treatment and using buprenorphine. A lot of non-whites, if they are using medical treatment, are using methadone as their treatment of choice because of costs. Usually the methadone clinics are, a lot of them are federally or locally funded, and it doesn't cost as much as going to a private doctor to get buprenorphine, or even to get into treatment, because treatment, as we all know, is very expensive, and there are very few treatment centers that cater to patients that might be of lower economic status. Even in terms of pain management for non-whites and whites, even though the white patient might have a lower pain scale, they're more likely to be discharged on opioids versus non-white Hispanic. Nobody knows why, but there is a lot of disparity in this space. And it starts from pain management at the hospital for pregnant women and postpartum, to opioid use disorder, to treatment. And you asked me earlier if some of it has to do with fear, and in the Black community or the non-white community, fear of their physician, fear of incarceration, and so they might be somehow, under the radar because they're fearful of sharing their drug use with their provider. They might anticipate that the provider would be judgmental, look down on them, and treat them differently. So I don't have the answer, but from my personal evaluation of these patients, and we see a lot of opioid addicted patients, and most of them, I mean, I would even say in our area in Florida, and we see all sorts of people because we have a practice in Wellington, we have it in Jupiter, we have it in Boynton Beach, we see patients in West Palm Beach. So we see a lot of people, and majority of the young ladies that come from treatment programs on medical therapy are white as compared to non-white, which is much different. When I started here, there was a lot of use of cocaine, and that was mostly, not 100%, in our Black community.
Do you think, doctor, there is a stigma against Black women who are pregnant and or addicted to opioids that leads to poor outcomes for those women and for their babies?
Yeah. So the stigma, yes, and that's not, that's a absolute yes. There's a stigma. So if you're Black and using drugs, people might tend to treat you a little differently than if you're non-white and using drugs. There's more there's more uh, empathy for your condition. And so the Black woman who might be using drugs, again, like I said, might be more fearful. And if you're more fearful and you're not seeking treatment, then your outcome may be worse. You might be more prone to preterm delivery, small babies. And if you're polydrug user, abruption, hypertension, etc., might be more prone to having your unit, your family unit disrupted because of substance abuse. Now, I don't know the statistics in the United States, but this is just my personal observation.
So, doctor, can you explain the difference in the stigma between minorities and whites?
Certainly. So, minorities in general, and again, this is a generalization, when they have substance use disorders, tend to be seen as bad, as a criminal. Uh, and this might affect the way their provider interacts with them. It might affect how the hospital interacts with them. It might affect how uh, they choose to seek treatment or not, as opposed to whites. And again, in general, when they have substance use disorder, they tend to be treated as a patient with a problem and tend to have more support throughout their journey with substance abuse. And because of that, they might have improved pregnancy outcomes.
Dr. Jones, if you were in a position to make major changes to improve treatment for women that are struggling with opioids, what would those changes be and why?
Yeah. So I think from my experience with opioid addiction, the two things that jump out is the fear of incarceration, and then the fear of the family services taking away their child. And this is even if they're in treatment. This is even if they're putting their best foot forward, trying to do the best that they can. There's constant fear of the legal system for, like I said, incarceration, and from family services removing their child. So I think that in order to have women be more open, more honest about their medical condition, just like they would if you had, like I said, diabetes or high blood pressure, we should remove, if we could, these legal barriers to care. That's what I'm going to call them, legal barriers to care. Also, the stigma needs to be removed. And particularly with minority patients, they have got to understand that this is a medical disorder, that there are programs, people, funds to help them. And if they come forward, that they will not be penalized for it. They won't be incarcerated. They won't be, um, their children won't be taken care away from them, and they can have good prenatal care, improve their outcome. The other thing is, uh, and this is the hard part. I was thinking about this earlier. The hard part would be to try to identify them prior to them becoming pregnant, which is tough because on a good day, 50% of women who get pregnant, it's not a planned pregnancy. So if you couple that with substance abuse, it'd be a little bit more challenging. But if we could figure out a way for women to reach out and say, I have a problem prior to pregnancy, uh, and we can treat them and perhaps help them completely come off of all medication, or if they are need of medication throughout the pregnancy, throughout their journey, then you can appropriately dose them, get them on the lowest dose, and they can, be on birth control until they are, if they believe in that, until they are ready to have a family. So that's the hard part about any medical problem. Even my diabetics, even my ladies with BMIs and high blood pressure, it's always good if I can get them to be their best self prior to becoming pregnant. But that's tough. But in a perfect world, that's what it would be your best self before you get pregnant. Be able to form a good working relationship with your care providers. Trust your care providers. Your care providers have to be non-judgmental. Treat them like they were their brothers or their sisters or their cousins. And educate women, which is very important, so that they know what uh, what to expect when they're pregnant. What are the things that they're doing in their lives that would impact their pregnancy? So educating women about it would be marvelous also. So that would be my big dream, is to how to improve pregnancy in general, and especially with substance abuse.
Dr. Jones, we have a lot of doctors in our audience this evening. What is your advice to them?
Well, it's tough. Is I'm going to acknowledge that treating patients with substance use disorders is. I would advise them not to get frustrated. Uh, if they could identify women who are of reproductive age that they suspect have substance use disorder, they can do two or three things. One, they could engage them in a conversation, an open, non-judgmental conversation about their um, use of drugs, smoking also. I'm going to throw that in, and encourage them either to seek treatment, or they can also send them to maternal fetal medicine specialists like myself. We do preconceptual counseling. We can speak to them about their substance abuse. And if we need to, we can collaborate with psychologists. We can collaborate with substance abuse specialists if we need to. Some of us can do treatment ourselves with the use of buprenorphine, which is uh, quickly becoming the drug of choice to treat pregnant women with opioid disorder. Do not hesitate to collaborate with your colleagues, because these are very difficult patients, time consuming patients. Um, and a lot of our colleagues are versed in uh, caring for patients with substance abuse disorder.
Dr. Jones, thank you so much for joining us. I'm Sandy Collier. We'll see you again next time.
Thank you for having me.
Sandy Collier, and thank you guys for joining us this evening. I have the pleasure of having Dr. Angelica Johnson here to talk to us today about opioids. Dr. Johnson, before we get started, why don't you tell us a little bit about yourself?
Hello, Sandy. Thank you so much for having me. Hi, my name is Angelica Johnson. I am a pediatric emergency physician working here in West Palm Beach, Florida.
So tell us about where you went to school and why you chose pediatrics.
I went to school at Drexel University in Philadelphia, and then I went to residency at East Tennessee State in Johnson City, Tennessee. I went from the city to the country, and that was a big difference. I chose pediatrics because myself, I grew up poor in a very small town in Illinois, and it took a village to get me here, and I wanted to give back to that village, and so that's the reason why I chose pediatrics. I wanted to take care of the kids. Building a great, strong foundation, to me, made me realize that it makes nice, healthy adults.
Wonderful. That's great. So let's jump right into our session. Can you explain your role working with children who have been affected by the opioid epidemic?
Yes. I currently work, like I stated, as a pediatric emergency physician. I sometimes see patients who come in with broken bones or they need another procedure, and I have to prescribe opioids to them. But majority of the times when I actually do give opioids is to my sickle cell patients or to my cancer patients, because that pain is very intense for them and they need a little extra help to kind of get through it. I also see at times teenagers who actually have opioid misuse or opioid addiction, and I have to help them kind of get through the initial struggle of it before sending them to a psychiatric hospital for extra treatment. I occasionally see the infant who had the neonatal abstinence syndrome, but I saw a lot of that during residency. I don't really deal with that as much anymore. I normally see the side effects from them having those withdrawal symptoms as an infant, which includes poor weight gain, and they have poor suck and swallow, and they would need to stay a couple of nights in the hospital to get their nutritional status back to normal.
So let's talk about what are some of the signs you're looking for in determining, talking about infants, if a pregnant woman has an opioid addiction.
It's very similar to seeing a non-pregnant female with an opioid addiction. We see the constricted pupils, we see the euphoria that you come along when you take these drugs. They have abdominal pain, constipation. It's very similar to that. What we do in order to identify these patients is to take a thorough history and physical exam, because either they will tell you or you can see it on the physical with track marks or with their pupils, and that allows us to identify them.
Tell me, you mentioned earlier about neonatal abstinence syndrome. Let's talk a little bit about that. What is the syndrome? What are the risk factors? Ways to support both the mother and the baby, as well as treatment options, and what is the protocol for monitoring infants with this syndrome? I know that's very loaded, but I'm sure you are prepared to answer that.
So neonatal abstinence syndrome is a syndrome that we see in infants, withdrawing infants. It's common symptoms. Usually we see about 21 common symptoms, including they shake, they're very tight, because when we pick them up, they're very tight. We see them sneeze, they have diarrhea, they have a lot of symptoms, and they're very irritable and fussy. And we see that commonly in these children. But as we talk about this, we always discuss that opioids are the drugs that causes these kids to have this neonatal abstinence syndrome, but that's not always the case. There are other drugs out there, including benzodiazepines, which are used for anxiety, and there are also barbiturates that are used for seizures. Caffeine can also cause infants to have this neonatal abstinence syndrome as well. But we don't know which drugs or how much of each drug that you would take would actually cause these infants to go through this withdrawal process. So we monitor them all, and we start to do this scoring protocol at 24 hours of life, and we monitor them for at least 5 days in the newborn nursery prior to them going home. Some of the risk factors, again, includes moms who are either on a prescription drug, including Subutex or Suboxone, which helps them to kind of get through their opioid use. Or they have street Subutex and street Suboxone as well that they can buy. We see a lot of these infants, they come to us, we monitor them, but sometimes they just need a little extra help, and they have to be sent to the NICU, which is the neonatal ICU, for extra treatment and for extra help. And we treat them with replacement therapy, including morphine and clonidine. And then we continue to use our scoring protocol, which is called the Finnegan score, to monitor these children and to withdraw the medication as tolerated. We go based on the babies. The babies kind of tell us what to do and how they want to be treated instead of what we want to do.
So you just started talking about the Finnegan scoring. Tell us a little bit more about that. What is it and how does that work?
So the Finnegan score is a score protocol that was developed in 1975 due to the rising opioid epidemic. They were seeing a lot of infants at that time that were withdrawing, and they needed a way to quantify how bad these infants were withdrawing. So now we continue to use it in our practice, but it's a very long scoring system. It kind of goes through 21 of the most common symptoms that infants use, and we give each symptom a score, either from 1 to 2 or 1 to 5. It's, like I said, it's very long because they have to go through 21 of these symptoms. Wow. It's extremely long to do, and it's a little tedious, especially for some of our nurses who have to see a lot of babies at one time. They usually score them every 3 to 4 hours prior to them feeding, and a score less than 8 means that they are having minimum withdrawal symptoms, so they can be monitored in the regular newborn nursery at that time. If they start having scores greater than 8, especially 3 or more, then at that time they are sent to the neonatal ICU. The way we kind of treat these infants with those lower scores is we do comfort measures. We swaddle them, we hold them. Again, I said they were very irritable, so we tried to keep the lights dim, we tried to keep the sound to a minimum. We make these babies comfortable. We use a pacifier with Sweeties, which is sugar water, and infants kind of get addicted to sugar water. And so we use that in order to treat these infants as well. But if they do more, if their numbers are elevated, then at that time we send them to the neonatal ICU for that replacement therapy, which includes morphine and clonidine.
How difficult is it to work with babies that are in such a crisis state in terms of withdrawal?
In my experience, I found it pretty difficult because in order to treat these infants, you have to make them comfortable, and it's very hard to make them comfortable at times. You hear the shrill cry, they're very fussy, they're very irritable, and no matter how hard you rock these infants or how tight you put their swaddle, they still are very fussy. And so it's very hard to treat them. They love to be held and they love to cuddle, but still it's very hard. And then they don't have great suck and swallow, so sometimes you're feeding them and they just cannot eat well, which makes them even more fussy and even more irritable. But I found it extremely difficult because it broke my heart to see these infants going through this.
In your experience, do you believe that pain is adequately treated in the pediatric population? And how do you determine what is the right amount of pain medication to prescribe to a child?
That's a tricky question because we have been studying pain in the pediatric population for a couple of years now. In the past, it definitely was not adequately treated because we would think that children did not either feel pain or they were easily distracted, and we didn't think that they were having a lot of pain problems. But we know now that children are actually very sensitive to pain, and we have to treat it appropriately. But the way we kind of monitor these is that in pediatrics, or just in the medical field in general, we love a scoring protocol. And so we use a number of different protocols, but the most common one that's used is the FACES protocol, which is kind of a stick and figure drawing of a face, where you have a face, the 2 little dots for the eyes, and then a smiley face, a frowny face, and some tears. And you have kids point to what face that they're feeling at this point in time. That protocol is usually used for ages 3 and up, and it actually works very well. There's another protocol out there that's pretty popular too. It's called the Oucher protocol, and that's a pretty cool one. I actually like that one, but it's a little too complex for the younger children because it's actually using real life people faces in order to justify their pain. And it uses multiple ethnicities so they can pick out who they look like the most, and then it actually helps the older kids kind of be able to identify their pain a little bit better. But in the younger kids, they do better with the simplified drawing, so they do better with the FACES scale.
So, Dr. Johnson, I'm fascinated about hearing about infants, so I want to go back to infants again. What steps do you take when treating an infant who is showing symptoms of pain? Can improper pain management have long-term effects on a developing child? Let's talk a little bit about that.
Okay, thank you for asking that question. It's actually a nice question to ask because it's harder even to treat infants with their pain because they can't talk to us. They don't use words. We have to go based on their body language. And so again, pediatrics, we love a good scoring protocol. So we use the FLAC protocol in order to quantify the infant's pain, which is face, we look at the legs, we look at their activity, see if they're actually able to be comfortable. We look at their comfortability and their crying. And then we kind of justify, we give each one of those a number from 0 to 2, and then the highest one is 10, which means that infant is in a lot of pain. So we use that scoring protocol in order to determine how well an infant is doing with their pain management. And we also look at their vital signs, which include their blood pressure, because blood pressure for pain people is higher. Their heart rate is higher. They can sometimes be, their temperatures can be elevated as well. And then we treat based on how we see the infant's vital signs, and we see what their score was. If the pain isn't properly treated, yes, it definitely can have a long-term consequence on these infants because they can withdraw from social contexts. There's also been studies to show like these infants can develop ADHD and hyperactivity in the future. Sometimes they can have like hypersensitivity to pain, so their pain tolerance is decreased. They're actually extremely fussy and irritable as they get older as well because the pain is just inadequately treated. We see some developmental outcomes as well where they're having poor testing performance at school, and they just can't pay attention in school because again their pain is not managed properly.
So, Dr. Johnson, let's go back to kids undergoing chemotherapy and sickle cell. How do you approach pain management in those children?
Thank you for asking that question. That pain is actually very protocolized. So we treat them with opioids and with an NSAID, and a lot of times I treat them with Toradol if they come in. So they kind of get a double whammy because those kids, they go through a lot of pain. There have been newer studies showing other pain treatments, other treatments that are not necessarily used for pain, including ketamine. But again, that's not used as widely, especially in children at this point in time. We use, again, opioids and NSAIDs to treat those patients.
Dr. Johnson, if you had the power to make changes in the whole opioid crisis in terms of kids, what would that be? What would you do?
That's actually a very difficult question to answer because it's a very complicated situation that we find ourselves in. I don't necessarily think children are affected primarily from actual opioid drugs. I think they're affected secondarily, and what I mean by that, it's not them that is taking the medication, it's their parents, and it affects them mentally, developmentally, and socially. I think they're not necessarily getting all the love and support that they need from a parent who has actually experienced opioid overuse or addiction, and I think it really does harm the child. And so I personally would like to offer a lot more resources to these children to make sure that they feel that they're not alone in this process, and to know that just because in the situation that they were actually born in, it doesn't mean that it has to be the situation that they need to stay in.
Do you find more in the poor areas in our community that we find a lot of opioid addiction, or is that just a myth?
I don't think it's a myth. Opioid addiction affects all type of ethnicities and all type of communities. I find that sometimes we tend to hide it a little bit better than other people, but I do see it in our community as well, especially in the emergency department where I actually have to hear everybody's secrets, or I have to discover what's going on with these children. And you'll be surprised the amount of kids who come in who parents say one thing, but then you do some tests and you figure out that it's actually an opioid issue that they are going through all alone.
We have a lot of your colleagues here listening to this, and I'm going to allow you to take some time to give them some advice. What would your advice be to them?
Hi, colleagues. So, my advice to you would be to not be afraid to treat pediatric pain. I know that there is an opioid crisis going on at this moment of time, but not all pediatric pain needs to be treated with an opioid. You can treat it with Tylenol or with Motrin. But I would say, don't be afraid to treat the pain, because kids do experience pain, contrary to popular belief.
Dr. Johnson, thank you so much for being here with us. We learned a lot from you, and thank you for what you're doing for our community.
Thank you so much for having me. I really appreciate being here to be able to discuss pediatric pain.
I'm Sandy Collier, and remember to take care of yourself and each other. We'll see you next time. I'm Sandy Collier, and thank you for joining us for this part of our series. Dr. Nakisha Forbes is here with me. Dr. Forbes, thank you so much. I enjoyed speaking with you before we started filming. We're both from the Bahamas.
Yes, ma'am.
Interesting. Bahama girls, right? So tell us a little bit about yourself.
Hi, as she said, I'm Nakisha. I'm Dr. Nakisha Forbes. I'm from Turks and Caicos, born in the Bahamas. Grew up in Turks and Caicos, and I have been living back and forth here since I was about 11.
So let's talk about, how did you decide to become a doctor?
It was when I was younger. Being the eldest of four, I was always the one that was playing with my siblings and having them be, the sick patients. I wanted to do medicine long before I even knew what it was. I just knew I wanted to take care of sick kids. So my siblings, they were my patients growing up. My mom would tell me I would be the one that would make them lay down and just play sick so I can fix them. So it's something that went on with me all through college, and I changed majors in college from nursing to pre-med, and here I am.
So wow, it's been in your system all along, and now you're living the dream. So tell us actually about being a pediatrician. Tell us about your background as, working as a pediatrician.
I did my, you mean in terms of where I went to school?
In terms of where you went to school, some of the patients that you've been dealing with, how does working in rural America compare to working with children in urban environments? Let's talk about a lot of that.
Okay. So I went to medical school in the Caribbean, and then I did an internship in Georgia, which is more city-based. So I got that experience living and working in the city part of America. And training, when I was done, I moved to Alabama, and everything was rural. I was it. I was the ER, the urgent care, the primary doctor, the cardiologist, because the nearest hospital, the nearest children's hospital in Alabama where I was 3 hours away. So there were times when I had to splint a leg or, do a soft cast, resuscitate, and then by ambulance get the children where they need to be. So
that was interesting.
It was something.
How does that compare to what you do now?
Well, what
have you learned back then that helps you now?
I learned resilience. I learned temperance. I learned to sometimes just be firm and sure in what I know, and which was something I struggled with in residency. Being sure of myself. Once I went into rural medicine, I was it. So I had to get a stiff backbone and just do it, and believe in myself that I can do it. And so there were times when I had to make the hard call. Do I admit this kid to the hospital, or do I send this kid 3 hours away from family? Or do I have them transferred to a local ER, then have them sent on? So in a sense, it helps me to be present in the moment and make fast decisions. That can be critical sometimes, and especially in the case that of kids that are having cardiac symptoms and are really having a hard time.
So of course we're talking about opioids. So how do you determine how much pain a child is experiencing, and when is it right to prescribe opioids for a child?
Right. Well, I have to say it depends on the situation. It depends on the history, and that's one of the first things that we gather when taking care of any patient, we want to get a detailed history. What happened? How did the injury come about? How much pain the child is in? And these questions are usually, always related to the parents. We are addressing the parents because they are able to be the voice for the child in the case of a young child. And in the case of a teenager, sometimes they can tell you more than the mom can or the dad can. And then a detailed physical. We want to address where the child is hurting, locate the source of the pain, if there needs any other like intervention or interaction with the family on a whole, or anything like an x-ray or something like that. Those things are tools that we can use to determine how much pain it is, how much pain there is, or the severity of the pain, or the severity of the problem that's related to the complaint.
So, what pharmaceutical drugs are given to children who are experiencing pain? And this is a two-part question. And are there specific symptoms that a child must exhibit before determining the use of opioids? You just started to talk a little bit about that in the evaluation process. So let's talk a little bit more about that.
Well, in terms of patients, the ones that I have had in the past, they have come to me already on medicines. I was referring back when I was in Alabama. Those were patients that I definitely may have had to put on opioid medicines depending on the severity of the pain, a fractured leg or a broken arm. Here, since I've moved to Florida, they have come to me on the medicines from the ER or from the urgent care. And so therein lies the conversation that I have to have with mom so that she can tell me, okay, how has he been doing? How has she been doing? Have they been walking around on the leg? Have they been moving the extremity? Have they been asking you for the pain medicines? How much medicine do you notice have been missing in the bottle? Keeping an accountability, and that can give me an idea of, what progress or what direction we're heading in terms of treatment.
Wow. And so that those details are very, very important for the parent to be able to...
Lots of interacting with the parents, yes, in terms of having a feel for how things are going, how things are progressing.
Do you see a lot of kids that are probably on opioids and they're getting more addicted to it? How does that work?
I see that mostly in teenagers because in the younger population, we don't always put them on opioids. We try like Tylenol or Motrin first, and then we build and see how things are progressing. And again, it depends on the situation. In teenagers, the ones that come to us already on medicines, it's a matter of getting a feel for them. And once we do, then we can, determine how we go about getting them off the medicine. So if it's a matter of reporting, frequent visits coming into us to see us, and then, we can assess your pain one-on-one that way, that sometimes helps.
How do you manage acute versus chronic pain in children?
Okay, so in an acute situation, we know it's a matter of an accident or something very traumatic that has happened. Or, for instance, a kid comes in with signs of appendicitis, acute abdomen. Those patients, we off the bat know that they're going to need a lot more help more quickly. And so we do start them, in the hospital setting on, stronger medications, whether it's Tylenol with codeine or something stronger. But in a sense, we try to get them off even that before they're discharged. In chronic patients, we always still want to find the source of the problem because sometimes treating the source treats the pain in chronic situations. Like the kid with constipation, they have pain. They will always complain of a sore stomach. My tummy hurt all the time. My stomach hurt. My stomach hurt. So those patients, we want to get a feel from mom. How often? How long? When did this start? We want to find out what makes it better, because sometimes just changing their diet makes their chronic situation go away, and we don't have to start on pain medications. Now we have the teenagers that come in with their chronic situations, and they will tell you what they want, and most time It is codeine, Tylenol with codeine, or it's Percocet. And so it's a matter of, once again, a lot of pediatrics is sitting down and talking to the patients and just hashing things out sometimes, especially with teenagers when we have the time, because they feel like it hurts, fix it now, medicine. Versus it hurts, what's making it hurt? What can I change to make it not hurt? So in situations where kids have sprains, they come in, they have a sprain, they keep using the leg, stress fracture. It's a matter of just talking one-on-one, following up. Sometimes I have to follow up with a sprain, especially in football. They want to keep on going, They don't want to rest it. And so I give them that accountability visit. Okay, how are things going? So following up constantly will help with chronic issues. Where over time, they realized they didn't need the medicine because they did what I told them to do, which is rest and do the basic things like ice and compressions and heat pads and stuff like that.
So talking about teenagers coming in and knowing exactly what kind of pain medication they want, what are the factors that lead to opioid abuse in adolescents, and how can these rates be reduced?
Yes. So signs that I've noticed where they're coming in and telling me things is one of them. And then we also look at the risk factors in terms of their surroundings. Are they surrounded by family members who use
friends?
Friends who use drugs, who use alcohol, siblings that are older siblings that are using. It's a norm, and the music and the media and the television. It's now common that even they see the smoking and the snorting and stuff like that. So they're used to seeing those things, and it's a matter of let's try that. I've had patients come in with the vape thing in their pocket.
Wow.
To see me. And yes, we have a discussion of coming to Jesus on that in the middle of the sibling having the visit, but the teenager is the one I'm going to talk to right there and then versus setting up an appointment weeks later.
Right.
Address the situation right there and then. And sometimes the parents, they don't even know the kid's vaping, but...
And that's dangerous as well.
Right. And so it's something that it's a matter of just being cognizant and just keeping a sharp eye and looking out for. And then ways and other risk factors also include the chronic patient, the patient with mental issues, the patient who are always agitated, even from a small kid. They're very high strung and, highly addictive to being attached to things. And so those kids that we try to curtail those urges and those impulses from early on, whether it's through therapy. We try to get them, into a program where they can address and identify these addictive behaviors before they become something that, they're dependent on in terms of seeking that reward, that satisfaction as they get older, because it's only going to build as they get older.
If you don't deal with it.
If you don't deal with it from the ground up. Yes, ma'am.
Wow. If you had the power, doctor, to make a change to be able to help to combat the opioid crisis, what would that change be?
That change would personally be for me to be more fearless in talking more about it with the parents in a way that, it'll make them be more comfortable talking to me about when they see things not going right with their children, because some families feel like it's their problem, their personal problem. They don't want to address it.
If it happens here,
keep it there. I would like to open that dialogue to where the parents feel comfortable reaching out to me as the child's pediatrician
or the healthcare professional.
Before it becomes a problem. And that's even in the younger stage where the kid, the chronic patient, she's noticing that they're needing more and more medicine. If they have a low, their pain threshold, their tolerance is low. Those are the kids also, like I mentioned earlier, that tend to get addicted fairly early. So if she feels comfortable reaching out to me and talking to me, challenging me, that'll help too to address situations before it gets out of hand. I think that's something that will help.
We have a lot of your colleagues listening this evening. What is your advice to them? My advice to you in handling and
staying on the battlefront with the opioid crisis is, I would say, to be vigilant and to, as much as you can, to, believe in yourself and believe that you have a voice and that you can help to advocate for the child. Sometimes, you may be that only person that can see what happens. And to be fearless and to believe that you can make a change or come over to the parent, come across to the parent, not as a authoritarian type of mentality, but as a friend, to make them understand that you're doing this for the betterment of their child, versus, just telling them what to do all the time. I think that will also help in the long run, because a lot of families, they have the concept that we're just telling them what to do, and we don't want that. So if we can, come across and just come to the table and just sit and just get to the bottom of things and have a dialogue and talk to the families and talk to the kids more. The younger that you can start, the better, going forward. I think that'll make a lot of change.
A lot of difference. Dr. Forbes, thank you so much for being here. You're doing a great job.
Thank you.
It was a pleasure to speak with you.
Thank you.
I'm Sandy Collier. We'll see you again next time. Next week, we'll hear from a clinical pharmacist with a new role on the front line, no longer counting pills.
And we have to make sure that we let them know when something doesn't seem right or this might not be the right choice for this specific patient.
And from a dentist with an extra set of eyes from the chair.
Patient. Before we prescribe a narcotic, we have to look at the patient, see their history.
On behalf of our organization, we would like to thank you for electing to take this opportunity to learn. We also would like to thank our team and panelists for helping us make this project possible. If you would like more information on Leroy Jefferson Medical Society, please visit our website at tljmedicalsociety.org.